Writing in progress.
Welcome everyone. Welcome to the midweek session, expert session in the FHIR Basics Learning series by the FHIR India community. Today our expert is Dr. SBB, and we will be talking. He'll be talking about healthcare terminology, what the importance of healthcare terminologies, and how terminologies help in interoperability. So I'll let Sir Dr. SBB introduce himself and take it over. Over to you, sir.
Thank you very much, Kumar. And good evening, everybody. And welcome to this midweek experts interaction on related to FHIR. Without further ado, I'll just state a few things about myself. I'm a health informatics expert, and I'm also a general medical practitioner with more than 37 years of experience. I worked with several MNCs, including Oracle, GE Healthcare, and TCS. I provide consulting services to digital health information system vendors and healthcare institutions in interoperability and data standards. That's my website for my company. I'm an adjunct professor in Chitkara Business School, Chitkara University, Punjab, where I teach data standards and interoperability. Well, actually not just data standards, I teach all of health informatics standards. And here, I'm also a member of Health Informatics Sectional Committee, Bureau of Indian Standards, which should explain why standards. I'm also a PRSG member of several healthcare IT projects funded by MeitY, Government of India, and this is Gita is a private, it's an entity within CII. I'm also a jury member of Digital Health Awards from FHIR. And I have been involved in formulating EHS standards for India, MOH and FW, Ministry of Health and Family Welfare, Government of India. As you can see, I have been working on standards for now close to 15 years, almost non-stop. And this is my personal website. Feel free to go there and read all about myself. And now I will start the real discussion on health terminology. So why do we need this? I mean, it seems that, is there any need? Of course there is. Healthcare is empirical, which means it's observational. You do not do anything without having observed some things and then making your own decision based on your analysis and your expertise to decide what you need to do in order to manage whatever the issue is. So we make records. And the records are meant for reuse and the information they contain for repurposing. So you just don't you don't make a record just to store it somewhere. I still remember in Hyderabad, I won't name the institution, it's a very famous, very old government-run institution where the medical records department had a storeroom which was like almost like a tennis court of size and height, and you wouldn't believe that the moment you entered the place, there were records all over. They had probably about 100 years worth of medical records all strewn all over the place. I mean, you're trying to find out anything, good luck. Worse, even if you get the record, you cannot reuse it because they are illegible. The information they contain, you also can just not use for clinical care. You can do with so much of analysis and many other things. So you repurpose them. So people will make record entries. This is very important. And this is why terminology is required. Based on their language of choice, level of expertise in writing in that language, training in the domain, current physical and mental state, need for speed, resulting in typographical errors, grammatical errors, and cryptic entries. It is crazy like. So in India, almost everywhere you go in the allopathic system of medication or medicine practice, you will find people will be writing irrespective of where they are from, north, south, east, west, they are writing in English because that is what we are trained in. And we will write in local language only when we are giving a prescription to the patient, which basically goes away. It's not with you. Although many of the institutions will have a carbon copy kept, and we are talking about paper-based only at the moment. Then your expertise in writing in that language. I mean, frankly speaking, we doctors are not very good. We generally tend to ignore anything outside of sciences. So English is not really our strong point, and we do not write very well. So there are a lot of grammatical errors, which is why even in this day and age of GPT, probably this is one of the protection that one has. You cannot use those generative AI LLMs for doing much based only on Indian records, because it might be a little, even the machine would have challenges. Then you're training in the domain. So supposing I'm a general practitioner. If I were to write something for related to oncology, it would be only up to a certain level. I would never be able to write to the level of expertise which an oncologist would have. Then also my current physical and mental state, the way that I'm writing would also be affected, because if you see any of our handwriting, we have lovely handwritings, calligraphy, which you call medical calligraphy, which is a special way of writing our records. They are something, even sometimes we cannot reread our own records. Something we have written earlier, we just can't, we look at it just as a matter of fun fact. If you can't read it, what we do is we send it to the chemist. They can read it. I don't know how they do it. Anyway, the need for speed. That is also another reason why we write, our handwritings are terrible. Okay. However, the challenge is machines need precision. Coded standard terms provide that. So you see how we are getting away, waiting from free text to precision requirement, and for that we need codes. So structured over unstructured data, although this was true before the advent of LLMs, today it's still important. Structured data has its own place of use, but the argument that was there previously, that you couldn't make any sense of unstructured data, does not hold true anymore. So things are changing. Just as a matter of point, before I forget later on, if you have something in unstructured data which is written as a free text, so supposing you have English data, no problem. But when you go to, let's say you are now studying Spanish records or French records, Canada, very frequently you will have they have dual language. So you will have, I mean, a doctor would either be writing in English or French. I mean, I don't believe they would ever be doing a duplication. But they are the unstructured data. LLMs would not be able to handle that simply. I'm sure work will be going on, but it will take some time. Whereas if you have coded, you can do it immediately. I'll show you a little bit. I cannot show you too much because we do not have that much amount of time, but I'll try and give you a flavor of what all is possible. Okay. So we need to process information instead of data. I'll be coming to this very important aspect. So please understand, information and data are not synonyms. And we need to process information, not data. So who are the consumers of health information? Primary ones are the clinical care providers and researchers. I mean, they are the ones who primarily consume health information. The secondary ones are the patients. And the tertiary ones are institutional care providers, payers. Quaternary ones are all others, like the law or public. So whenever any record is there, primarily it will be consumed by clinical care providers, and later on, after repurposing, by researchers. Secondarily, by the patients, because normally they would not be looking at their own records, but they will get a summary. And of course, they will get a prescription. Tertiary is only once the care has been provided and things have progressed or the patient has been discharged, the institution is interested in the information for, of course, for their own internal assessment purposes, but more importantly, to get payment and pay us definitely for that reason. And once we are all done and dusted and everything is been taken care of and archived, you have quaternary. When the law will come into play after you have the patient is some resolution has happened. Now I'll come to data, information, knowledge, wisdom, the DIKW paradigm. So now let's look at what is data, information, knowledge, and wisdom. Data are discrete facts. So appendectomy, please note the difference in the spelling. Past, current, planned, emergency, and you understand the rest of it. Or simply you have appendectomy. Now, when you read the word appendectomy, it has got, you don't know in which context it is being used. It could mean, what do you mean by appendectomy? So we need information. Information is what required for our information management. That is why we call it not data management, but information management system. So information is, it has got contextual facts. So they are distinct facts. So they are contextual data or contextual facts. So now let's see what we mean by contextual. Past history of appendectomy. Now we are making some sense, right? Patient advised emergency laparoscopic appendicectomy, acute appendicitis, chronic appendicitis, interval appendectomy, 6 weeks. So simply how to do appendectomy. Not how to do actually, but in what context? Because of the temporal relation of that or severity when we talk about acute or chronic. What is knowledge? Knowledge is information compendium. So patient has chronic appendicitis and requires appendectomy for resolution. This one sentence is knowledge. So when to do appendectomy? So let's say, should I do the appendectomy or not? No, my knowledge will tell me whether I should or shouldn't do. Now, there is something called wisdom, which comes later. And with age and experience, I'll tell you that. It's knowledge application. Patient should be treated with a course of antibiotics first, before doing appendicectomy, after 6 weeks, and not operated on immediately unless it is life-threatening. This is wisdom. And simply, when not to do the appendectomy. A famous saying goes in surgery, all surgeons know how to operate. Most surgeons know when to operate. Few surgeons, but the experienced ones know, really the good ones, when not to operate. Famous saying, my since departed, my professor of surgery. Now we come to semantic interoperability. We talk about a lot of interoperability, but remember, just pure interoperability will not work for healthcare because it's empirical. Remember from the second slide, the third slide, we need semantic interoperability. So now what do we mean? Interoperability is the ability to exchange information. I now do not remember exactly, but a couple of years ago, I was pretty shocked. There was this PhD in computer science from IIT Madras. I happened to be interviewing him on behalf of the government, and I asked him this question: can you explain what is interoperability? He just simply couldn't answer me. He just simply stared at me. I said, all right, fine, let's move on. But that was so disappointing at a level. Now, semantic interoperability is just not the ability to exchange information. It is ability to exchange information without any loss of meaning for effective use of the exchanged information by interpreting it. So, semantic interoperability will ensure that not only the information has been exchanged, but there has been no loss of meaning. The meaning is retained. And the meaning is information. You see, you exchange information, you don't exchange data. What does effective use mean? Effective use means that the information can be used in any type of computable algorithm as appropriate to that information. And semantics, what does the word semantic mean? Semantics is the inner meaning of a term or phrase. We will be talking about semantic interoperability a few slides down when we discuss SNOMED. So documents are records of thoughts of the person creating them, that they express using language that evolves over time along with the knowledge that it represents. See, nothing is static. So not only the people change, see, also your life, just think of it from your life's perspective. I mean, I'm sure you must have visited many doctors since you were a child and you have recollections of. So the persons changed. The way that they expressed or wrote also changed, because every individual will have his or own way to write what they're thinking or their observations. And the language also evolves over time. And frankly speaking, I remember when I was young, I was a child, my language, my parents would say, you are using a lot of new words. My grandparents would say, oh, look at him. We used to say it like this. And I used to think, oh, these old fogies, oh my God. Now I am the old fogey. I do not always understand what my children say. And the younger ones are even worse. I could make no sense. I mean, I'll have to do some extrapolation. But that's the way they are. I was shocked. This time I had gone to visit the reunion of my alma mater, Calcutta Medical College. And I was listening to Bengali after a long time. I'm born and brought up in Kolkata. I live in Faridabad, but I am born and brought up over there. So I don't get to hear Bengali other than the Bengali I speak myself. The problem is, when I went there, I found that all these kiddos, okay, so they are all quite accomplished consultants themselves, but much younger to me. And they were using language which was difficult for me to understand. And they were not speaking anything clinical. They were having a chit-chat. The knowledge also evolves. What you knew earlier, all your convictions are now changed. I don't have that slide over here. I have it somewhere in my archive, that the same condition, how it was treated in 1300s, 1900s, and in the 21st century. It was fascinating. So because the knowledge changed, so you had more equipment, more understanding, and therefore, so I'll just give you an example. So if you had some chest pains and you had some infection, I mean, not infection, I mean, you had some fever, even in 1300s, you would go and pray. That was your only recourse. And by the time of 21st century, we are asking for a chest X-ray and putting in the person on antibiotics, etc., etc. Right. So now we come, and I have deliberately put in this slide because there's a lot of confusion regarding what is a code. What does the word code mean? I've been shocked. Most people do not have a very clear understanding. So a code is a symbolic representation or identifier of discrete information. When we say discrete information, any information which is a term, meaning, image, object, etc. What can this symbolic representation mean? It can be alphanumeric, numeric, image, like QR or barcodes, alphabets only, etc. So your QR code is also a code. Your barcode is also a code. Your bus route number is also a code. PIN code, postal code, zip code, all of them are code. But they are a symbolic representation of some identifier of discrete, representation or identifier. It identifies some discrete information. Why do you code? Why do we need code? for machine processability. Just think of it, when you're doing a UPI, you just simply go and scan that QR code, and the rest of it is just you put in your PIN, and you just put in the number, how much money you have to put in, and the PIN number, and it goes, and it's done. It's so easy because the machine is processing everything behind the scene, underneath the hood. Semantic interoperability. Codes need to be machine interpretable. You just cannot just only machine process. You have to also make it interpretable when we are talking about healthcare. Healthcare is very critical. Time is of essence. Sometimes a minute may be too long. The person might die. So there, everything is instantaneous. That is why paper-based is now being increasingly found to be not helpful in a critical care setting, especially. In semantic interoperability, what do we have for code? We have terminology systems, which accomplished directly due to the ontology of standard terms. And classification systems accomplished indirectly due to using standard terms. Then we have information integration, information pooling from various sources for reuse and repurposing. Provide accuracy, billing, reimbursement, quality assurance. Facilitates triggering, clinical decision support, management of clinical workflows and tasks. And we have to also support analytics, categorization to identify health trends, track clinical effectiveness, support health research, etc. So what are medical codes? These are also called controlled medical vocabularies. We'll see some examples. So what are they? A standardized set of terms and codes used to represent medical concepts, conditions, procedures, and treatments. These are designed to improve the accuracy and consistency of clinical documentation, make it easier for healthcare providers to share and understand patient information across different systems and platforms. Helps achieve better outcomes. What are the types of medical codes? These are called classification systems, where the term itself is coded. I will give you examples of this. Group similar terms. They are monohierarchical, helps in locating terms of similarly grouped ones, and useful in epidemiology. Unfortunately, you will see, okay, I'll leave that discussion a little later, how we are repurposing the code for completely different things, which it was not meant to be in the first place. Then we have something called a terminology system. The meaning behind the term is coded. Terms that mean the same have the same code. So in SNOMED, appendicectomy and appendectomy both are valid terms, and they both have the same code. The way it is structured, it is done because it is a terminology system. It is polyhierarchical. So you can use any one of these hierarchies to do the aggregation. Helps in both location and interpretation of terms. See, you cannot do any interpretation of terms in classification systems. You have to do it by adding another logic layer to it. Whereas in terminology system, the logic layer is already built into the code. And it is useful in its semantic interoperability. And hence my repeated posts everywhere. I keep on saying this, harping on it. It's almost ad nauseum now. That you cannot do semantic interoperability without terminology systems. Period. Anybody thinking otherwise is making a fatal mistake. Fatal in the sense, in the terms of digital system not able to deliver the real value to the end users. So here are some examples of code systems. These are controlled medical vocabularies. So let's go by one. So we have got ICD-11. This is the latest. That is why I have taken that. ICD-10 is still being used, but we are already doing migration. So what is coded in ICD-11? You remember? It is a symbolic identifier of some discrete information. The information is what is coded. So the term of title of the disease is coded. For example, E2E80 is benign lipomatous neoplasm. And the purpose is morbidity and mortality statistics. Then you have RX norm. Medication item is the discrete information, and this number 483017, 100 milliliter acetaminophen, 10 milligram per milliliter injection. So this is for medication item identification. Then you have CPT, common procedural terms. Procedures are the coded. Example 99213, an office or outpatient visit with an established patient involving a moderate level of evaluation and management, E by M, complexity, evaluation and management. E by M is evaluation and management. So it is to describe medical, surgical, and diagnostic services for billing and documentation. It's so easy to bill. You know what has been done and how much effort has been put in. So you can bill accordingly. It is easy to cost and put a price to it. Then we have LOINC. This, what is coded is the test name with FSN. FSN, just because it's an acronym over here, FSN, the full name is fully specified name. So here 45037-9 is actually bacteria producing urease. Then you have a lot of other stuff. Just a fun fact, LOINC is mostly to program autoanalyzers. That is why you need LOINC. LOINC is not really for human consumption. Well, none of the codes are, but whatever that it is talking about, the test name with FSN, that is not for human consumption. It's very cryptic, as you can see. If you expect some doctor to remember this, something wrong. So investigation item identification, it's not really that, it's observation. But it's commonly understood as investigation item identification. Last and probably the most important one is SNOMED CT. It is concept definition of terms. That is what it goes coded. And as you can see, 4972702 is actually cuff. And note what is written after that. It's again very cryptic because this is, the machine is supposed to interpret this, not the human. But just to make it understandable to human, it basically means it is a respiratory function finding. And it is found, the finding of the cuff is found or is the place where it is located, or the problem or whatever respiratory function is at respiratory tract structure, right from, it starts from your nose and mouth right up to lungs. So anywhere there could be a reason why the cuff is to be found, the reasons for the cuff. So the clinical term meaning identification. That is what SNOMED CT has coded. So I talked to you about a lot of SNOMED CT identifier. So now look at it. It's very interesting. It is just for fun, huh? Because to explain this will take me some time. I'm not going to do that. But just to tell you that this number is not supposed to be even displayed to the end user. Please understand. I have always said this, that if I see any system where this number is displayed, it means that the people who design the system do not understand SNOMED CT. So the SNOMED CT this number is only for machine consumption. Now there are two types. As you can see at the top, this is a smaller number, and the larger one, this of course there are certain reasons, but this number is, both are valid numbers. It is not something that I made up. So excision of appendix, which is the meaning of appendicectomy or appendectomy, that is the number, and the lower one is actually of some, it is what it says is India NRC maintained module. So NRC maintained module will all have this as module ID. And then there's something called a partition identifier, but very interesting, it has got a check digit. The last one is also like the 2 on the top and 8 at the bottom. So you run that algorithm, and that is what it computes. So now, if for any reason that last number is not, so that check digit is not passed, the machine knows that there is something wrong with that number. It is inbuilt. So you can see that this number is going to point to that meaning. So as soon as the machine sees this number, first of all, it will be able to process it, identify whether the entire thing has come or not, and then it would be able to interpret it because it will just go and see what it means or what it is pointing to, and we'll be able to unravel from there. LOINC, on the other hand, is also interesting. This is the number where there is a mod 10 check digit. It also has a check digit. And the number, all numbers before the dash is actually that FSN. So all you can see is that it's all, I have given you a breakup of this. It's coming in a few slides. So now let's see. I've been talking about SNOMED, but you do know that a lot of other codes are used. So how do you resolve this situation? Very simple. You have to do something called a mapping. So LOINC to SNOMED. So you have the source code of the term and the target code. The target code here in this particular slide is SNOMED. All of that number, you can see it has got that 0000, and there is one at last number. If you run that algorithm check, you will get those, you'll be able to generate those numbers. So LOINC, that number would be mapped to the one in the target. Term, discharge to home, that is the target code. That is the SNOMED code for discharge to home. So ICD-10 K35.8 has got that number, and ICD-03 morphology would have that number. Topology, that is where it is located. So morphology is the abnormality. It's all to do with oncology. So those are the ones. And you even have MEDRA. So MEDRA code, and that will map to its target code. By the way, all of these codes that I have shown you, they are all official releases. So you can, if you have the code which is in the source or the term, you can reasonably expect to get the target code by automated coding.
Sir, can we take a couple of questions?
Yes, sure.
It's in the chat. I'll just read out. Vinay Kumar is asking, can you explain the SNOMED CT? Can you explain the SNOMED CT and ICD? I heard SNOMED CT is built upon ICD. How these integrate in EHR?
I will. These are coming. Just hold on.
Okay, then we'll take the questions at the end.
Yeah, let's do it at the last, because probably many of these questions would be answered.
Sure.
Okay. So classification system, I told you. The term is coded. So now appendicitis. In classification system, ICD-10 code will say appendicitis will be found in between K35 and K38, which groups all the diseases of appendix. And what are these? Acute appendicitis, other appendicitis, unspecified appendicitis, other diseases of appendix. So as you can see, I don't know how many of you are clinicians or medical doctors yourselves, but I can tell you, being a clinician myself, these terms are not clinician friendly, at least these ones. See, acute appendicitis, yes. But I want to say chronic appendicitis. So what do? Now I have to be trained. Is it other appendicitis or unspecified appendicitis? And supposing I have something to do with some other condition which can not be classified into these two, then I have to put it as other disease of appendix, which does not make any clinical sense to me. Next time when I see this number, unless I have written the diagnosis, I would struggle big time. It will make no sense to me. But it is great for doing epidemiology studies, because acute appendicitis is something that we are very interested in. Other appendicitis, we are comfortable doing an epidemiological study. Disease prevalence, disease incidence, all sorts of survival rates, blah, blah, blah. They're all come under epidemiology. So what is an ICD? ICD is International Classification of Disease by the WHO and provides a method of classifying diseases, injuries, and causes of death used to record and track diagnosed diseases worldwide, and helpful in conducting research on diseases, their causes, and their treatments. The ICD contains the treatment of all known diseases and injuries. The core of ICD-10 uses one single list of four alphanumeric character codes from A00.0 to Z99.0. The first letter of the code designates a different chapter. There are 22 chapters in total. Within each chapter, 4 character codes specify different classification axes. You really have to study in order to understand what is all going on. I saw a question about, okay, I will address that. Just let me finish this one. What is a terminology system? I told you, meaning of the term is coded. I've taken the same, exactly the same one, appendicitis. And now I have done it in SNOMED. In SNOMED, appendicitis is defined as disorder of appendix, inflammation of large intestine, which is found in appendix structure, and is associated morphology is inflammatory morphology. Now guess what? It has 33 subtypes, and subtypes of subtype like acute appendicitis, amoebic appendicitis, acute focal appendicitis. All terms are very clinician friendly. Now you see, the machine is now on, I've been talking my lingo. So therefore, if I have coded it correctly, the machine will keep on informing me every single time what I had written. There will be no ambiguity. So what is SNOMED CT? SNOMED CT uniquely codes the meanings behind a term and are machine processable. These meanings are logically defined as encoded entities and relationships that always remain valid under all circumstances. It never changes. These concept definitions are machine interpretable, encoded information models. If you will recall, you saw those numbers there, right? For every single human readable stuff, there was a corresponding number. That is the encoding of that particular. So you can actually find out what does the word appendicular structure mean. You can find out what is inflammatory morphology. You can find out what does one mean by diseases of appendix. All of them are defined. So now, because all of them are defined and all of them are themselves codes, the machine can totally take it apart. And you ask them any question, it will be able to give you answers in sub-second. It's brilliant. All synonymous terms, irrespective of language or dialect, have the same code. Every code has a unique, official, readable, fully specified name, FSN, with the concept's domain as semantic tag, enclosed in parentheses as suffix that explains the concept in a non-vague, simple to understand manner. Okay. Yes. So the question was that about SNOMED. I will answer all of these questions once I'm done. I'll take one by one. That will be easier. Okay. So ontology based. I'll try and finish it within the next 5 minutes. Ontology based, which means ontology means knowledge representation, basically. Take it as a very vague one. So the Loing code 806-0 is actually the fully specified name is this funny looking stuff. In the long common name, which is more clinician friendly, it is leukocytes, numbers per volume in cerebral spinal fluid by manual count. You can see it is written over here. PT it's instantaneous. CSF, and it is a manual count. See, it is a manual count. And leukocytes, you can unravel, but you will have to really look hard. Please understand, all of these are actually strings. not codes. So the machine, for the machine to interpret, you will have to build in another logic. The short name is WBC hash CSF manual. This short name is to be used for reports as report column heading. Ontology based, I told you. So logical observation identifiers, names and codes. This is the full form of LOINC. It has a LOINC number, which is a code. It's also called LOINC code. And a fully specified name FSN, which is composed of 5 or 6 main parts, hence the ontology, that is knowledge representation. So what are those 6 parts? There are 5 mandatory and 1 optional access. So there is a name of the component or analyte measured, like is it glucose, propanol, etc. Property observed, is it substance concentration, mass, volume. Time aspect of the measurement, over time or momentary. So type of system or sample, like urine or serum. Scale of measurement, qualitative versus quantitative, and where relevant. That is why the first 5 are mandatory, the 6th one is optional. The method of measurement, how you're measuring it, you may or may not write, like ready immunoassay, immunoblot, UC, manual count also. You saw that in the previous one. Also has a long common name, which is a clinician friendly term, and a short name useful for display in lab reports. It's publicly available at no cost and endorsed by the American Clinical Laboratory Association and the College of American Pathologists. I saw in the Zulip some questions regarding code, coded system, code, and others. I will explain. It is coming in the next slide. So now these, from here on, this is all FHIR specific, HL7 FHIR specific. So coded values, code systems, value sets, concept map. So code systems define what is code systems, define concepts and give them meaning through formal definitions and assign codes that represent the concepts. Value sets specifies a set of codes defined by code systems that can be used in a specific context. Now the first one, the examples would be SNOMED and LOINC. They define the concepts and give them meaning through formal definitions. FHIR basically tells you have to use either SNOMED or LOINC as appropriate. The value sets are where they tell you there are other alternatives also. It's not just these 2, but this is only for clinical work. The non-clinical, there are other codes also, but they have all been specified through the value sets. It's all been given. For every resource that it is given, wherever there is a code that requires to be used, they have given the value sets. So bindings. Apply a value to an element and specify the rules around the use of a value set. So an element, whatever the element in the resource is, it is to be bound to a particular value set. And these bindings are what is called terminology bindings. Concept map. What are concept maps? A statement of relationships from one set of concepts to one or more other concepts, either concepts in the code system or data element concepts or classes in class models. This is what a concept map is. So bindings actually bind a particular element to a code. A concept map will actually is a statement of relationships, concepts to other concepts. So code to code, you might say. Now, why code to code when I'm saying that it is all defined concepts? Because many places you have homegrown codes. This is why concept mapping is required as well as bindings are required. But binding is not really the term for that. We have to use the word concept map. We call it mappings. So a local code or a term is mapped to a proper code or a value set within a code system. So coding, codable concept. Somebody asked this question in Zulip. Code, what is a code? They're not the same, by the way. Code indicates that the value is taken from a set of control strings defined elsewhere. So this could be your SNOMED code, ICT code, or a local code. so long as there it is defined and some master data is kept somewhere. Your local codes will also have some master list somewhere. Then it becomes a code. Coding is a representation of a defined concept using a symbol from a defined code system. So coding, when you say coding, you are actually not using a local term or a local code. It is one of the defined code systems. And a codable concept represents a value that is usually supplied by providing a reference to one or more terminologies or ontologies, but may also be defined with the provision of text. More than one code can be used, and the concept may be coded multiple times in different code systems. So you can have the same information. I'm deliberately using the word information. And you can have it, the same one can have multiple codes. No problem. As long as you use a code. It's a bit complicated, but it is. I hope it is clear. But anyway, so binding a value set to element. Binding is applying a value set to an element and specifying the rules around the use of the value set. The set of coded values that is allowed in an element is known as a value set. Anywhere the data types are used, these data types, that is a value set. The specification binds a value to the element, and for coding and codable concept, it always does. It's a bit cryptic, but it is straight from your FHIR website. Mixing and matching of standard codes such as SNOMED CT and LOINC and homegrown codes is not recommended and will fail to support interoperability. That is why you need coded concepts. Concept mapping, sorry. If you do that, then you will be able to support interoperability, otherwise it will not. Because your homegrown code will not match somebody else's homegrown code. How will they find any commonality? How will they do the conversion? They will not be able to do it. The code system identifier of the concept is necessary for interoperable data exchanged. So whenever you are sending the information, you have to say what is the code system that you're using. So there is a URL or a URI that you have to provide. You will see in your resource, it is given, or the profiles, it is provided. Terminology binding, there are certain types of terminology binding required. Most elements of type code have a required binding. For example, status elements. You have to give it. You have to give the code. Extensible. Such bindings are commonly found in profiles. Indeed, narrowing the binding to a specific required value set is one of the basic things profiles exist for. Preferred. Such bindings are suggestions from these developers of resource and profiles. It is not valid to provide just a text when there is a required binding. So if any particular place the binding is supposed to be required, you cannot just provide a text. In extensible or preferred, you may. Preferred is a suggestion. So you can simply ignore it. But extensible, it is better you give it. And profiles will tell you that for this one, you have to use this value set. ABDM profiles are extensible. With SNOMED and LOINC, the code sets mandated for non-investigations, that is conditions, observations, allergy, problem, procedure, etc. Map and mapping. This is something like I'm asked to do a lot, but the point is that it is not as simple as it appears to be. You just simply can't take a term and map it to something. A map is a collection of associations between codes, concepts, or terms in one code set, the source. If you remember that slide I had shown previously, to codes and concepts or terms in another code set, the target, that have the same or similar meanings. So I have to now figure out, if I'm doing the mapping, that whether my source, the meaning of the source, matches the meaning of the target. If it does not, then I've not done a proper mapping. You just can't simply take two strings and match, and if they match, then it is the same. No, it's not that simple. It is developed in accordance with a document-read rationale for a given purpose, and as a result, there may be different maps between the same pair of code systems to meet different use cases. So you have to do an extensive documentation. There are about 9 or 10 documents that have to be prepared. Ideally, it's not done, but it should be. Mapping is the process of defining a relationship between the source and the target code's concepts or terms. You have to say how you are doing this relationship. So I saw one question regarding maps from ICD to SNOMED and others. I will address them. So just bear with me. Semantic interoperability and terminology binding. Semantic interoperability is information exchange without any loss of meaning, helps make effective use of the exchange information by interpreting it. Terminology binding makes local terms and local codes standard code sets compliant through mapping. Makes information consistent and facilitating. What does it facilitate? Reporting, improved accuracy for billing and reimbursements, quality and performance measurement, health and research analytics, public health monitoring. So I hope I've been able to explain that semantic interoperability and terminology binding are not something that are similar. They have their own distinct flavors. Also, clinical decision support. That is what terminology binding will allow you to. And if you do not use standard code sets, then you do not have semantic interoperability. And if you do, then you will be able to get the information consistent so that these 6 points that are there from reporting to clinical decision support are all facilitated. ABDM compliance, use of HL7 FHIR is mandated. FHIR profiles, you can find it from this. I'm sure most of you know about it. Since significant amounts of information are captured at free text, it is crucial to ensure terminology binding is done as early in the development or system release cycle. Many people delays are likely to make retrospective changes and implementation for legacy data expensive. Kicking the can down the road is not a wise option and not advisable. Many people think, no, let's not think about doing any mapping now. Let the government make it mandatory, and we will see when it is required. Merely because your data will not be static. The number of records will keep on growing, and because of the many ways the records are kept, you will be left with each which would have been a simple project will become an extremely complicated project. So you thinking not spending any money now, you're not really saving anything. You're just making it, in my opinion, not a very wise choice, because later on, it can be only done by a very large team who will ask for a very large sum of money, which might be prohibitive. Exercise, do we have time? Okay, I had some exercises, but I don't think so we will have time.
We can do the exercise, sir. Not a problem.
Okay, we can? Okay.
Yeah.
So what I will do is I will just escape this, and I will escape this because I'm done with the presentation. So I will now share a new one. So just give me, I will just stop sharing and then I will go back to a new one, because I have to change first I will do the SNOMED. No, not the SNOMED, the LOINC one. Okay, I think you can see my screen now.
Yes.
So I had some, so I will have to go through, but just bear with me. Your screen sharing is paused because I have to get those names. So just give me a moment. I will do that for you. So I have not done this. This has not been a very good homework done by me. Somehow get it done. So I'll just copy this for my own use so that I can easily do it. So give me one moment. Okay. Why did I open this one? Sorry about this. I'll stop the sharing because this is causing a lot of trouble for me. I'll just come back. Okay. At last we are. So I hope you can see my screen. So I'll take the first one. So the first one is this particular name. So you will see this actually is a free browser, and all of you can get access to it, no problem. The only thing, this is for Loink. You will have to register. It's a free registration, and then you can use it for doing your own search. So it's pretty simple. You go to search Loink. It's a little tricky to locate this particular browser, but you can just simply go to loink.org/search/ and you will get this. So here you put in there and you do the search. And here you are inundated with, I think there are 17 names which it is found. Now you see the challenge. Which one is the correct one? Now, if you give a guy like me who is doing the mapping and you simply give BUN, BUN, urea nitrogen serum, I will have a big problem to decide on which one you are looking for. So I always insist that you will have to give me the details of those 6 axes I was talking to you about. The more you give me, the better it is for me to find the right one. So here, it is more than likely it will either be this first one, urea nitrogen, moles per volume, or mass per volume. Because the other ones are ratios and stuff. So this would not, there's a 70-minute. So you can, I can instinctively say, but I cannot make the distinction between these two unless I know whether the reporting is going to be moles per volume or mass per volume. So let's take the next one. And I have used very standard names. CA125. Let's see if we can find anything. Yeah, we found. Again, you see, I have got 14 options and I have to search from them. It becomes more and more challenging. Calcium creatinine ratio 24 hours. Let's see that. It didn't find anything. So now another one. So I have to now reduce the string that I'm looking for. Now I got something. Here you see this one, 24-hour urine, 24-hour urine. So again, it is a choice between these two. It is a mass or a molar ratio. So you can see it is not always that you will just put in that thing into the search box and you will get the answer. No. But this is what local labs use. You will not get anything. Let's see. Bleeding time and clotting time. Now still no joy. So if I put in bleeding time, now I get 18 options. And the top one is the most likely one because it's coagulation. So this is what we know by bleeding time. But clotting time, let's look at clotting time. plotting time, but this is again, it is Lee-White method. Then you have a Sukarev method. So you have to know which method is being used. Most likely all the time we use Lee-White method. I don't know what is the current one, but during when I was regularly working, I mean, doing my clinics, I'm an occasional practitioner. I don't practice on a regular basis. All right. And I've got the last one, blood group ABO typing. I actually have taken it from a list provided by a lab. I've directly copy pasted. Yep. So this is the first one. 882-1 is the most likely one. But there are 22 options I need to choose from. Okay, so I'll stop sharing this and now I'll go to my most favorite one, SNOMED. I can see JP is already there. Okay, JP, don't get worried. All right. Can you see my screen?
Yes.
This is a free browser. Anyone, there is no registration required. You can just go and use it. So this is the first one. If you go to browser.ihtsdotools.org, you will reach here. This is the first screen. And you have to do this go browsing. Interestingly, it is showing 1st of April 24. Tomorrow morning, if you check, it will be 1st of May because the release cycle is now every month. When you do that, this is what you get. Here, there is a release, which release edition you need, and I'll show you. It's very interesting. Not very many, but let's do appendicectomy I have chosen. So here, you can just simply type any 3 characters. It will give you a list. It will retrieve a list. But for speed purposes, I'm going to make it easier. So if you do that, you will get a lot of options. So now the first one seems to be the most obvious one. But now you have to check whether what you are saying is exactly the meaning over here. So this is called a focal concept, which is in the blue. Its parents are over here. So it is an operation on appendix and partial excision of large intestine. Its method is excision, action, and the procedure site direct is appendix structure. And you can see here, they have given options in language. So it is appendectomy, excision of appendix, appendicectomy. All of them are synonyms and all of them are valid. So the doctor can choose any one of them. It would mean the same. This will be the number. Now, you want to see it in Spanish. So I'll just change the language and see it is now showing. This is what is anybody speaking Spanish can authenticate this. It is authenticate, by the way. So this is in Spanish. So anybody who has written the record in Spanish would still get the same number. Now let's try the Canadian one. I could have done the Belgian, but Belgian actually would be more interesting. Hang on. Because in Belgian, you will get a flavor of 2 languages. They have got both French and Netherlands, that is Dutch. This FR, it's in French, appendicectomy. And in Netherlands, it is called appendectomy. And the rest of them are all in English because they have not done any changes. They've only done the changes over here. But whereas in Spanish is much more mature. So they have changed all of them. But in the Belgian version, it's only this one has been changed. Anybody interested in looking at the Swedish version? There you go. Anybody who knows Swedish can check for themselves. This is what it is in Swedish. So if you get a record from Sweden, you can still convert it into English. No problem. The way that you can do it is given. Okay, fun and games over. Now let's try with the next one. cholecystitis with cholelithiasis. This one will not come. It will come, but yeah, why not? See? It's actually written cholelithiasis with cholecystitis. So it is reversed. I wrote cholecystitis with cholelithiasis, and it just simply changed it around and checked it for cholelithiasis and cholecystitis, and it still came up with the, because it's the same. See, the meaning is coded. So even if the strings are not matching, you are getting the right code. See, it's so brilliant. And you can figure out what it is. It is both the cholecystitis as well as gallbladder calculus, which it is. And it has got finding, it is also found in, both of them are found in gallbladder, but one is a calculus, which is a stone, and then there is the inflammatory morphology, which is the cholecystitis. And it has got these many children, subtypes, and they have their subtypes of their own. These arrows means they have got subtypes of their own. Now let's take carcinoma and a couple of carcinoma ones. Adenocarcinoma cervix. Found out? Yes. You can get the code, no problem. CA breast. I deliberately use CA breast because that's how we write it. Now here it is very interesting. This is why I'm emphasizing about meaning. So breast cancer, CA breast is breast cancer, correct? And here you have CA breast cancer, and it has got these many different types of name. And you've got, but the actual, this simplest non-vague meaning is it's a malignant neoplasm of breast, and it has got its number. But as you can see, there is also something called a breast cavity. If you are not very clear, if you have just put in CA breast, you can also be meaning a breast cavity, but it is not. You mean it's a cancer of the breast. It can also be carcinoma of breast, which is not the same as breast cancer. Okay, I'll show you just meaning. It can be carbuncle of breast. It can be breast calcification and a host of others. So now let's see what is carcinoma of breast. It is a subtype of malignant neoplasm of breast. Okay. If you really want to know why this distinction, you'll see it is a breast structure and malignant epithelial neoplasm, whereas this one is actually a malignant neoplasm. In carcinoma of breast, it is the epithelial cancer. So there is definitely a difference. All of these are unique. It has to be unique because all the codes are unique. Last one is suspected COVID-19. Let's see whether it will come. Just to go to the browser. Yeah, there it is. Yeah, real mouthful. What does it fully mean? Suspected disease caused by severe acute respiratory coronavirus 2. And this is what it means. It is a subtype of suspected coronavirus infection found in, is associated founding what it is, that it disease caused by severe acute respiratory disease syndrome coronavirus 2. The context is suspected. The context, it is there. Relationship, it is who has the disease. So who is the subject? Is the subject of record. So we know exactly. And it is temporal context is current or specified. That means suspected, it is ongoing now. All of these details are available from SNOMED. Okay, so now I will address a few of these questions. I hope we have enough time. Yes, I will explain in ontology also. Okay, I'll go through one by one. And anybody having any question over and above this are free to ask. Can you explain the SNOMED CT and ICD? I heard ICD is built upon. No. SNOMED CT is not built on ICD. They are chalk and cheese. They appear the same, but two different things. I would rather not say chalk and cheese. I would rather say apple and orange, because they're both codes, but one is a classification system, another is a terminology system. How to integrate these in EHR? Well, for that you will require a whole month of tutorial. Just a tip, ICD implementation, you will have to, it is now available. Previously, up till ICD 10, it was not available in a digital format. But now with ICD 11, it is totally digital. So you will have to integrate it. There are no terminology servers, but SNOMED CT has terminology server. If you use it, like this browser was using a terminology server. So that is where it was collecting all the data, all the information from there. CVX codes for immunization, I'm not very familiar with CVX codes. I have not done any work. I will not try and pontificate or pretend that I have done. It is there. I have heard about it, but I have not worked on it. Vaccine codes, no, I have not. I can tell you. Can we think SNOMED as a superset? It has got observations. SNOMED has observations as well as medication. And every month they are releasing, because they are increasingly adding more and more medication items as clinical drugs. It's very detailed. Hopefully within another 6 months time, you will have the entire, all the, I mean, very generic, of course, but they will provide all the generics through that. But I have some interesting news to share. Our NRCS, which is the India extension, which is the India National Resource Center for handling SNOMED, they also handle all EHR standards related work, Pune based. They are coming up with an India specific extension of medication items, India drug extension, they call it, where this is, they have gone even beyond SNOMED, so which they are allowed to do. So they have also included brand names and suppliers and a host of other details. But those are outside of SNOMED. But because they have linked it to, they've used mapping basically. So there the source is SNOMED and the target is their own whatever brand name or supplier name or etc. etc. That is their target. They have done that. Why does we not use these codes like no ICD-10 is what the government of India had always, because it is available under India being a member of WHO. It used to get access to ICD-10 and it used to recommend ICD-10. And in fact, to the best of my knowledge, IRDA, Insurance Regulatory Authority of India, they have asked for ICD coding of all discharge summaries. SNOMED and LOINC are recommended, but the problem is it is still recommended because they have not yet made it mandatory to use anything like FHIR. Once they make FHIR mandatory, it will automatically become mandatory. But now it is more like a suggestion, but it is better complied now because later on the pain would be too much and there will be too much disruption of the business. But that's just one of them. Are there any specific place where we could get these mappings? Yes. Not ICD to 10. That mapping is not available. It is SNOMED to ICD. ICD 10, by the way. This comes as an official release. In every release, I was talking to you about release, like tomorrow morning, actually 5:30 a.m. or is it, yeah, 5:30 a.m. for us. It is 12 GMT, sorry, 00 GMT of they release the new release sets of international releases, and each of them have a officially vetted map for SNOMED to ICD available. NDC to RX norm, no, this is not available to the best of my knowledge. Why do we always need to opt for SNOMED? Very good question. It's because, as I was showing to you, we clinicians would love any system which uses SNOMED CT. It will make our lives extremely, extremely easy. We will just have to choose, like let's say appendicitis. Acute appendicitis, I will choose. The system will automatically can prepare a prescription for me from a preset. It will help me in getting rid of the repetitive tasks. Next, let's say task flow management. When we work in a team, especially in a critical care situation, if you use SNOMED, you can automate most of the tasks. So as soon as, let's say, you have some triggers that you complete particular task, and it is automatically the next person in the chain is alerted. You can do that all behind the scene and the machine, because the machine knows exactly what you are working with, what you are recording. It can read you. Can you again confirm whether we use, when we use, and what are the difference? Oh dear. SNOMED, as I said, SNOMED is a terminal system. LOINC, according to some, is a terminal system. Yes, it is, because it has got an ontology. It also uses, but it is, that ontology is not information. It is just information model, but not encoded. Whereas SNOMED is actually an encoded information model. ICD is just plain code to term. That is the title of the disease. And please note, ICD is very narrow in scope. It will only code diseases and injuries. Whereas SNOMED will code, well, they classically used to use this term, abscess to zygote, to emphasize A to Z. Everything that is healthcare, you will almost all of them you will get in SNOMED. So you can use SNOMED to code any part of a medical record, right from reason for visit to complaints, to history, to allergies, to immunizations, to physical examinations, including all the detail like auscultation, inspection, palpation, percussion, and auscultation. These are all technical terms, but just to emphasize, you can do that. You can do it for ultrasound findings, CT's findings, image findings. You can do it for any investigation order that you want to place. You can record vitals. You can have pathology reports. You can have imaging reports. You can have you can actually, I actually helped one organization in doing this. Based upon, let's say, the patient has some drug allergies, and it was recorded by somebody sometime, somewhere, but within that system. And some doctor who had never seen the patient before is now ordering a medication because he is in a hurry and did not take the history properly. So he didn't have the time to ask for the allergies. So he is now trying to order something which has an active ingredient to which the person is allergic to. The machine will automatically pop up an alert saying, this person is allergic to that. Are you sure you want to do it? It does not stop the doctor, but gives him a chance to correct himself. It will bring down our medication related errors quite significantly. What about DRG comes into picture, as we are using now? DRG, if you use SNOMED, you do not really need to do otherwise for specific purposes, like for billing. If you really want to do billing, you just find the corresponding CPT code. In India, we do not use CPT code, so I have limited experience of doing this map. But Crosswalks, to the best of my knowledge, is available because in US, HIPAA mandates SNOMED, and they have to use CPT for billing. So you will get crosswalks. Where do we get the mapping of SNOMED, LOINC to SNOMED? It is still in the preparation. Yes, you can go to these downloads, but you will get the LOINC codes. You will actually not get the SNOMED because these guys, there was a draft which was put out in 2017. Since then, they have not made any new releases. Now, we do not have the full information, but as of now, they are working at a feverish pitch to get one-to-one mapping between LOINC and SNOMED. So SNOMED is also adding a lot of something called observable entities. Those will be specific to LOINC. So you saw that in Loing, it is not coded, right? Those ontology is all string based. In SNOMED, everything is coded. So if you get something in Loing, you can just look up the SNOMED code for it, and you can do the machine interpretation from there. So Loing does not have to do that extra work of trying to encode it. It's actually a win-win situation. Are there any such code mappings available for reuse? I'm not too sure what you mean. Once you have done the code, if you have done the code, you just have to retrieve it and use it. I'm not sure what you mean. When we bid for a project, the tender number is also code. Yes, absolutely. Even a name is a code. Not really, no. Unless you have a name. My name is very long, so I make it short like SBB. So that's actually a code. SNOMED and yes, are mapped. Thank you. We have both way in place. SNOMED, yeah, this is available from these guys. UMLS. You can get it. Is it a one-to-many mapping? Yes, not the first one. The first one is not there. I mean, you can derive, but it is a little hazardous. The second one is one-to-many. There was a question on ontology in the last session. Explain the ontology concept here. Okay, yeah. Ontology is just knowledge representation where you put in that's for a particular thing. What are the meaning? You can say ontology in a way, in a very loose manner, it is a minimum data set. But it is much more than that. Now SDSC, check out what is tools available to understanding. Oh God. ICD 10, 11, effectively. Good luck. There are, but most of them are created by folks like me and NRCS. Go to NRCS. They should be able to help you out. But and Ministry of Health and Family Welfare for ICD 10. ICD 11 is very complicated. All the folks who are thinking of just going from ICD 10 to ICD 11, I can only wish them my very good wishes. Huh? It's really, really tough. And you cannot do it without admission. Go read resources. Okay, yeah, everything is available free of cost to read. Thank you. What is it? Full data, white blood cells. Okay, Loing, can you please explain? Loing codes. Loing codes are the numbers. And they are the system or the discrete, the identifiers, and they identify the ontology, which is the FSM, which has got 5/6 axes. Can you give examples of each for this table? Search, where can we find what code systems approved by India? Oh yeah, this is from NRCS. Yeah, there we are. Excellent. Can you give some examples as well? Code? No, I actually didn't have so much of time. I was always a little concerned because I have a tendency of going overboard. So I tried to keep it short. But if you really want, you can always ping me. Feel free. Language. Yeah, okay. New messages. A struggle. Yeah, you would. Wish you very good luck, as I said. Any suggestion for non-clinical person to identify right one? No. I would suggest that you don't try it. Mapping is very deceptive. It appears very simple, but it is not. I think I do not exactly remember how many pages it is, but SNOMED puts out a document on mapping, just on mapping, which is I think about 100 pages odd. And you should read it. It is a study of sorts. You find it difficult, it is terrible for non-clinicians. No, doctors should not find it difficult at all, because they will be given either limited choices of terms to choose from, which would be already mapped behind the scene. And remember, no end user should use codes. We humans are not made for working with codes. We humans are made for working with terms. human readable terms. When fill the gaps for coding and codable concept. As I said, you can ping me. I don't know. I mean, you have to talk to Satyam or JP if they want. I can take a short session on concepts.
Definitely, if there is interest, sir, we can take it. So please do vote on the Zulip. And somebody put a question, and then let's see the interest, and based on that, we can take it up. Yeah. Thanks, sir. In the interest of time,
sure.
Around 6:30. So what I'll say is, for the questions that could not be taken now, right? Please put them on Zulip, and this is for the participants. And then SBB sir or somebody will definitely answer them, right? We'll get it answered. Okay. And certain questions which are not making sense today, or the answers that are not making sense today, maybe once you are through with some of the sessions that we are having on terminologies and profiles and FHIRs, you'll definitely come to know how to work with them. Okay. And Zulip is our friend. So if you have any questions, even afterwards, right, and you want to reach out to SBB sir or anyone, right, you can just put in the questions. We'll get the answers. Okay. So thanks a lot, sir. This was a very wonderful session. In fact, I learned few things again today. So you're a wonderful teacher, that I must say.
Even I'm learning, yeah. I still am learning. I have not stopped learning. I mean, every day. And I'm sure JP will testify to this. When I actually took a class, a session on, it was a very long one, when I was teaching SNOMED, and that was so long. Even I got exhausted. And those guys would have been fed up seeing me. But today I can do the same thing much faster. But I'll give you, this is terminology is very dense.
Thank you, sir. Thanks a lot. And thanks everyone for participating today on 1st May. And that is actually a holiday for the majority of the folks. And tomorrow we are coming back at 5 o'clock. Again, this time we are coming back with ABDM and FHIR. Like, so what's ABDM doing with FHIR? So some of the things that SBB sir talked today, we will be seeing that also tomorrow, right? So what is the use of FHIR in ABDM, right? So with that, let's take a break. We'll meet again tomorrow. Thanks a lot for joining. Bye-bye.